All right. Good morning, everyone. This is Maria Maddox with the Illinois EI Training Program. Welcome to Webinar Wednesdays. Our topic today will be Prader-Willi and Angelman Syndrome. And our presenters today are Adam and Katie Larson. Adam and his wife are the Vice President of the Prader-Willi Syndrome for the Illinois Association chapter. Welcome. Also presenting with us today is Dr. Cindy Chestaro, and she is a Developmental and Behavioral Pediatrics Fellow at the University of Chicago. Moderating today's session is, again, myself. If you've been participating in any of these webinars, you will see I've been pretty much doing most of them. Stepping in for Susan today, and I don't have a lovely picture, but is stepping in is Alyssa Jones, and she is with the EI training program as well. And so she and I will be kind of coordinating today. So if there's any questions, Alyssa knows pretty much all there is to know about how these webinars go. So that's them.
Good morning, everyone, and thanks so much for participating with us in this webinar. It's pretty interesting to see that most of 46%, right, have never seen this syndrome. So I am pretty excited that we'll be able to share more information about and be more aware of this, because I think we'll be seeing it more as we are able to identify them. So as Maria said, I'm a fellow in developmental and behavioral pediatrics, so I'm pretty interested in following the developmental outcomes of medical conditions, and I do work in several sites for medical diagnostics, so it's been something that I really, really enjoy. And I am pretty excited to share this presentation with Adam, and you'll get to meet his handsome boy. So that's one of the coolest things about this webinar, that you'll be able to hear from him the parent's perspective. And I'll be just giving you an overview of the medical implications, and as you see in the objectives, so we'll talk a little bit about genetic inheritance and the developmental and behavioral outcomes of this, and understanding supports and resources for families, which is a very interesting an important topic, as we'll hear more in the future. So going forward, as in my particular practice, I've had the opportunity during residency to take care of 2 or 3 children with Prader-Willi, so I was able to be like their primary care along with the endocrinologist. And now, like a year ago in fellowship, I was able to meet a family with twins in Angelman. So in 14 years of training and studying, I've only seen a few of the syndromes. So let's start with Prader-Willi, and this is a complex genetic disorder. It's resulting from an abnormality in the chromosome 15, and it's good to remember that this condition presents from birth, and the name comes from the physicians who first described it in 1956. So they saw 9 kids with, it looks like the characteristics of the boy on the left, that it was short, obese, with small hands and feet, and had intellectual disabilities. So one of the things with the syndromes is that the diagnosis is not made until the child's several years of age. And that's historically, because nowadays, with the increased awareness and the good genetic testing that we have available, we can make a diagnosis in infancy. So the mainstay for this diagnosis is genetic testing. And moving forward, this condition is present equally in both genders, so boys and girls. And we have all geographic regions are, so all races, and the incidence for this syndrome will be in about 1 to 15,000. So depending on the reports, some will be 1 in 10,000 or others in 1 in 30,000, but it's around that number. So although this is considered a rare disorder, it's one of the most common conditions that is seen in the genetic clinics as a cause of obesity. So switching gears to Angelman Syndrome, this is another diagnosis that was identified in 1965 by this doctor here, Dr. Harry Angelman, in similar story. So he saw 3 children with similar presentations, jerky gait, lack of speech, motor disorders, and a happy demeanor. So while he was vacationing in Italy, he saw this painting to the right of the slide, which is called A Boy with a Puppet. So when he first described the syndrome, this painting reminded him of the children that he already seen, and he described the syndrome as the puppet children syndrome. So, and again, this is another complex genetic condition of the chromosome 15, and this one has more of a neurologic implication. The epidemiology for Angelman is similar to Prader-Willi, so affects males and females equally and all racial and ethnic groups. And the prevalence is similar, so around 1 in 10,000, 1 in 20,000. So this, as conditions that you learned before prior webinar in January about Down syndrome, so you probably recall that this is a condition that we see 1 in 600, 700 kids. So definitely is something that we see more than these conditions as Angelman and Prader-Willi. So moving to generic inheritance. So these syndromes, as I mentioned before, are caused by an abnormality in the chromosome 15. So that we know. What we don't know is what causes this abnormality. So it usually occurs as a random event near the time of conception for an unknown reason.
So this is one of our polls that we have here. So if you would take a moment and identify whether you feel this answer, this statement is true. So the statement is, affected people typically have no history of the disorder in their family. So identify whether you think that answer should be true or false. We'll give folks 10, 15 seconds to respond. The responses are coming in. That's great. All right. Okay. So it looks like that 50% of the folks feel that yes, this statement is true. Affected people typically have no history of the disorder. Roughly 30% aren't really sure. So, so we'll see what the answer is. Cindy?
So yeah, as you, most of you said, so this is a true statement. So affected people typically have no history of the disorder in their families. And I actually, when I met with Adam, I was asking him, do you know any other families that have more than one child with Prader-Willi in this case? And it would say for the most part, none of them except for one family. And he told me that he knows about like 50 families. So he'll tell you more about it. So let's move forward. So in terms of the genetics of Prader-Willi and Angelman, I think this is a really fascinating genetic process that happens here. And again, both syndromes are caused by the abnormality in the same chromosome. So what happens here is a genetic term called imprinting. That refers to a gene, where a gene, again, as a reminder, is where all our genetic information comes as stored. And the imprinting refers to the fact that a gene could work or not work depending on the parent origin. So as we see in the picture here, so for most genes, we all have, again, 23 pairs of chromosomes. And for most genes, we inherit one copy, one working copy from mom and one working copy from our father. So with imprinting genes, we inherit only one working copy. So depending, again, on the parent origin, it will be either Prader-Willi or Angelman syndrome. So with Prader-Willi, let me just go over the pictures. Here is the Q12 refers to the imprinting cell. So this is the zone where the gene is located. Okay, so then with Prader-Willi, we have most of the cases are due to a deletion or a loss of genetic material from the paternal chromosome. And then we have a smaller percent of the cases that are called imprinting defects, so those are mutations. And the reason why this is really important to say is because when we have the specific genetic cause, it will tell us for counseling the recurrent risk. So and in this case, let's say most of the cases, as I say, like over 70% are due to a deletion of the paternal chromosome. So the recurrence risk for this family will be less than 1% to have another child because it's a random event. But then if the family has their child affected by an imprinting defect, which is again the less of the cases, then the mutation could have a recurrence risk of up to 50%, which is pretty high. In terms of Angelman, it's a similar presentation in terms of that more than 70% are due to a deletion in the maternal chromosome. And then the most important thing to remember with Angelman syndrome is that there could be a 10 to 15% of the cases that have a normal genetic lab. And this happened to me not too long ago while working at Medical Diagnostics in Erickson, where I had a little girl about to be 3 years old, and she presented with the clinical manifestations of an Angelman syndrome, but she was already seen by genetics, and they did all the testing, and everything came back normal. So one of the things that we have to remember is that you could have Angelman syndrome and have 10 to 15% of the cases of a normal genetic result. Another important thing to mention about this chromosome 15 is that there's literature describing that this chromosome may confer a susceptibility to autism. So we see characteristics of autism in both syndromes, in one more than other. So in Angelman syndrome, it's been described that some literature says that up to 50 to 80% some of the children will present characteristics of autism spectrum disorders. And actually this syndrome is commonly misdiagnosed between the ages of 2 and 4 years of age because of the same reason. The syndrome is rare, so autism, we know more about it, and even cerebral palsy has been the most common misdiagnosis for Angelman syndrome. So it is really important to be aware of this, especially since we're seeing nowadays more and more autism. So in terms of Prader-Willi, so they have some behaviors that could be, again, autism-like, so the temper tantrums, impulsiveness, repetitive speech, self-injuries, and skin picking. So again, not every, it's like a spectrum again, not every child will present with this characteristics, but with some systematic reviews that has been done in the past, some Prader-Willi kids will have either a 15% of chance to have meet criteria for an autism spectrum disorder, and other reports are even higher, about a 30% of the kids. So one limitation with our current literature is that these studies were done when we were not using standardized testing like we have today with the ADOS tool. That's something to have in mind.
Cindy, can I interrupt you here for just a second, just for verbal clarification? Susan, you had mentioned something about the skin, and so could you clarify that again? Because I think you were cutting out during that statement that you made.
Can you hear me?
We can now, yes.
Okay, great. So what statement you said?
Susan had just a clarification question on, there was a statement you made about skin issues, and so, but you cut out during it, so we weren't really sure exactly what you said. So if you could clarify that. Hello? Cindy? Cindy? All right. We may have, let's see if we can get Cindy back in here. Hold on just a second. All right, let's see here. Cindy got logged off and is logged back in, so let's see if she can get her mic working again. Right.
Yes, here I am. Sorry about that.
Yay. Okay. So, did you see the question that I had asked?
I couldn't hear you.
Okay, and maybe kind of a moot point now. You had mentioned something about skin disorders, I think, or something, and you had cut out during your presentation, and so there was just a clarification question as to if you could repeat that again.
I did not mention anything about skin. So
perfect. Okay. It might have been just a misunderstanding.
But we'll definitely go over the clinical presentations about both syndromes, if that will help.
All right, thank you. Okay, so folks, it looks like we have another poll. There's a lovely picture of a young man here, and the question to you is, which syndrome does this child have? So you have 4 choices here: Angelmans, Prader-Wili, unsure, or neither. So take a moment and see what your thoughts are on this. Okay, we'll give folks a few more seconds to respond. Let's see. All right. So it does appear that 46% of you aren't really sure as to what syndrome this child has, but if you were going to make a statement, 15% of you feel that this child has Angelman syndrome. So, all right, let's see what the answer is. So, Cindy?
Yes, so this child has Angelman syndrome, and we'll talk more about it. Let's go to the next question.
Okay, so here's another picture of an infant, and so see what you think your choices here are. I think we need to clear the old responses first, though, Alyssa. Okay, so if you go ahead and start replying again if you had just started. So there we go. Okay. All right, so folks are really charting in here. It does look like the vast majority of you feel pretty strongly that this child has Prader-Wili, and again, a portion of you are not certain yet as well. So let's see what the answers are. All right. Okay. So as you can see, this child, those of you who said Prader-Wili, you are correct. All right. Cindy?
Yes, that is correct. This is a baby with Prader-Wili. So go ahead, Adam.
Yes, good morning, everyone. My name is Adam Larson, and I am the father of a Prader-Wili child, and that is him right there, Graham. I had never heard of Prader-Wili syndrome until I was told that my son had it. And there he is. The picture on the left was the day he was born, and the picture on the right was a couple days later. So that is how they present. Our story was we had a pretty normal pregnancy with my wife expected to deliver on January 2nd, and everything was moving along according to schedule, except she woke up one morning that just so happened to be December 25th, Christmas morning, and told me that it was time, and I thought it was time to put the presents under the tree, but actually it was time to go to the hospital because she was in labor. So we got to the hospital and found out that we had to have a C-section because he was not in the right position to deliver the conventional way. So we went ahead, had the C-section, and he came out. And he came out looking pretty funny because he was folded in half, folded at the waist with his head down by his feet. So it looks pretty funny. Everybody kind of had a chuckle on that, and we thought he was pretty cute. We were happy to find out he had a boy, but quickly we realized something was wrong. Pretty quickly, every doctor in the wing came running in to see what was going on because he was floppy. You saw in the last picture of the Prader-Willi baby how his arms were out to the side. That's the same thing that Graham was doing. Yeah, see, just like that. If you know a newborn, typically they want to pull their limbs in, right? And when a Prader-Willi baby is born, he has basically no muscle control whatsoever. So instead, he kind of lays flat like that. Can't pull up his head, can't even really turn his head over, and can barely move his arms and limbs. Also, you can see there that on this boy, there's undeveloped testes. That was also the case for Graham. And of course, he also couldn't feed. And he couldn't cry. He made no sound whatsoever. So the doctors rushed in and said, well, he's fine. He's breathing fine. He's alert. He's got a heart rate. But there's definitely something wrong. So he was immediately admitted into the NICU. And we spent a couple days trying to figure out what was wrong with Graham. And it was on day 3 that a resident actually mentioned for the first time the words Prader-Willi syndrome to us. I think that picture on the right is about day 3. And me and my wife had never heard of it before. We ran home, got on Google and Googled Prader-Willi and had the living daylight scared out of us because we saw all the horror stories that are out there about Prader-Willi children. Prader-Willi is the leading cause of death by obesity in children. The dominant trait of Prader-Willi syndrome is a Prader-Willi child can never feel full. Prader-Willi kids are constantly seeking food. If you leave anything out, they will try to eat it. So the vast majority of Prader-Willi kids are extremely overweight. So in these early years of the syndrome, the early intervention years, it's a bit of a paradox because the children are born incredibly weak and they're unable to feed. So you see on the right, Graham has an NG tube put into his nose there. He actually came home from the hospital with that. And we learned how to feed him that way. A few months down the road, he had a surgery to put a G-tube in his stomach so that he could get fed directly into his stomach. So as parents, we brought home from the hospital a child who we couldn't feed through the mouth. We had to feed through a tube, and we had to feed through a machine. He also never cried. It took about 8 months before we heard Graham cry for the first time, which is kind of sad. You want to hear your child cry, but it's also a little bit interesting because we were able to get a good night's sleep right away, which is not something that happens with a normal newborn, but that was a little benefit, I guess, for lack of a better word. But for those first few months, the big therapy that we needed help from early intervention was speech, because we needed help developing his mouth muscles, control of his tongue, so that he was able to start feeding. And also physical therapy, because he had no core strength whatsoever, so we had to start building up those muscles to get him up and moving around. So for the first year or so of a Prader-Willi child's life, it's all about trying to get them to eat. And then for the rest of their life, you're trying to get them to not eat. So it's a little bit of a paradox. But it took Graham about 8 months or so. Once he got the G-tube put in, he kind of got the hang of eating orally pretty quick after that. So the G-tube only stayed in for about 2 months before we were able to get that out. And now Graham is up and moving around, and we are today. He just turned 3 this past Christmas Day, so he is now in preschool, and he's getting his therapies there. But yeah, this is pretty typical. I've met, as Cindy mentioned, I've met at least 50 Prader-Willi kids, and we had no parent ever has seen a Prader-Willi kid until they have one, and they all look the same. They look just like, they present just the same as that picture that you saw in the previous slide. So when our fellow parents share pictures of our babies, they all look the same. They all have a G-tube. or an NG2, and they all are very loose-limbed. They all can't control their head, and they're all very quiet. But they're very sweet. They're very loving. Yes, that is a good question there. There are varying degrees of Prader-Willi. It is a spectrum disease. What might be a weakness for one child may not show up on another child. And there are lots of ways that we are getting much better results now on how to treat things. One of the big things now that all Prader-Willi families are getting involved with, especially in the first year, is the muscle control issues are being dealt with growth hormone therapy. So in that first year, if you're working with a Prader-Willi family, one thing that they are going to be going through is learning how to work the insurance network to get insurance to pay for really expensive growth hormone injections. We give Graham a nightly growth hormone injection, which started right around 5 or 6 months in his case. Sometimes it starts a little bit later. But what you will see as a early intervention practitioner working with a Prader-Willi kid is whenever they go on growth hormone for the first time, and then subsequently whenever the dosage is increased, you will see a little jump in that child start hitting more milestones and start getting a little bit stronger. So that is something to look for. And one other point to mention here is we got the diagnosis of Prader-Willi on Graham very early. We had it, we first found out about it in day 3 or 4, and then it was confirmed via some tests about 2 or 3 weeks later. That is very early. A lot of kids in our experience don't find out what they have because there are so many other conditions that kind of mask Prader-Willi, so it's not often diagnosed right away. In one case, we have a friend who their boy had a brain tumor, so they were dealing with that for the first year, not realizing that all of his symptoms were not related to the brain tumor, but rather Prader-Willi syndrome. So a lot of first-year families aren't quite on growth hormone yet because they don't have the diagnosis yet, and you need that diagnosis to be able to go to insurance. So that's something to look at. So Cindy, do you want to take it to the next slide there?
Yes, thank you so much for sharing that. And I was able to catch up a little bit on the chat, and just to clarify, yes, I did mention something about the skin, but I was out of context, so I didn't recall it. So when we were talking about some of the behaviors that a child with Prader-Willi could present, self-injury behaviors and picking of their skin, which we'll see a picture in a couple of slides. So that's something that can definitely present with these kids, but not in everyone. And let's move forward. So historically, this syndrome was known as the two-stage syndrome. So the first, in infancy, you have the low muscle tone and the poor feeding and even failure to thrive. And then a second phase where there's hyperphagia or uncontrollable drive to eat, and then obesity. So now we know more with current literature that there's different nutritional phases in Prader-Willi, and actually it's 7 of them described, so different phases. The first one being in prenatal to birth, where we'll see decreased fetal movements and low birth weight. And then, as we see in the picture here, the hypotonia with the difficulty feeding and decreased appetite. And then with the clinical facial features that we could see in this case, so the high prominent forehead, the narrow bifrontal diameter, as we can see markedly in this picture of this child, the downturned corner of their mouth, and then the micrognathia, or the small chin that we see here. Then there's another phase that goes from 9 months to 25 months where there's an improved feeding and appetite and growing appropriately. But then the following one, which will be between the ages of 2 and 1 month and 4.5 years, there's going to be a weight increase without an appetite increase or excess of calories. And then further on, increased appetites and calories, but then they can feel full. And then further into the older years and adulthood, we'll see they can't stop eating and they rarely feel full. And then in adulthood, we can see that the appetite is no longer insatiable. So we see this little girl here. You can see the skin manifestations of skin thickening and the central obesity. And then we can see her scar from the feeding tube in early infancy. And then this was again, typically described 7-year-old boy, and you see significant weight, short stature, and then you see the knock knee that he has, and then the underdeveloped testes or hypogonadism.
Cindy, can I jump in on those last Cindy, can I jump in on those last 2 slides real quick?
Sure.
If you look at the 2.5-year-old right here, I wanted to speak on this because this child here doesn't look very healthy to me, because one thing I wanted to mention to everybody, diet is very important, and as we move from the newborn years into the more toddler years, what you're going to see with Prader-Willi kids is their families are working on their diet a lot, so they're working on low-carb diets. So I just wanted to mention to everybody who's in early intervention that what you're going to see as the children start to move away from tube feeding onto oral feeding is the families are going to really restrict their diet, probably to low-carb diets, so that you get children who don't quite look like this pretty girl here. When my boy was 2.5 and other kids who were 2.5, they kind of don't look like this anymore because we have a much better diet. So I just wanted to point out to people in early intervention that you're going to be working with families who are on very restricted diets, particularly in this phase of the syndrome.
So, thank you, Adam. So this picture is what we're aiming for. This is a couple of siblings, and one has 7 years old, and the other one has 8. And one has Prader-Willi, and the other one does not. And as you can see, none of them are obese. So which one do you think has Prader-Willi? And obviously this is not a poll, but just by looking at them, is there anything that you can identify that could tell you, okay, this one is, or maybe not?
Yeah, use that box and just see what kind of responses we get. That's great.
You wanna what did you say? Sorry.
Oh, I was just reminding folks just to go ahead and use the chat box and respond to the question. So it looks like folks are primarily picking the young gentleman on the right with the green shorts and the red hair.
Yes. So this is, again, the one on the right is the one that has the Prader-Willi, and you can note from his gastrostomy tube that was used in infancy, there's a scar in his belly. So this kid has pretty much normalization of his body characteristics from Prader-Willi, and this is all after treatment with growth hormone. Okay, so then moving forward with Angelman Syndrome. So this boy here is called Elliot. So this was published in a paper in UK in 2012. And the title was The Boy That Never Stopped Laughing Due to Angelman Syndrome. So this was the kid that we put in the previous pictures. And the characteristics of, the facial characteristics for Angelman will be coarse features. They have wide mouth posturing, wide spaced teeth. They have frequent drooling, and they're always smiling. They have a happy demeanor. So when they interviewed this family, they were like, well, when we feel down, Elliot's laughter keeps us all going, and you just have to look at him, and his happiness takes over. And the mom continues saying that at the end of the day, when you have a child, you just want them to be happy, and then Elliot always is. And the other thing that was interesting that you mentioned was that the only problem is Elliot's brother getting the wrong idea. So if Elliot, his big brother, Alex, was playing and accidentally hurt himself, Alex will be crying. But then Elliot will be just laughing, and he doesn't understand why. So that's something to remember with this kid. They're always happy. They're always having a smile on their face. So the clinical presentation for Angelman, there's a diagnostic criteria where we'll see that 100% of the cases, so all of them, will consistently present these features. So the developmental delay is usually very severe. The other one is a movement or a balance disorder. So it's usually ataxia of gait. This could be mild, so you can just see probably unsteadiness or clumsiness. And in terms of the behavioral uniqueness, as I mentioned, so frequent laughter, smiling, and apparent happy demeanor. In terms of the speech impairment, this is a very significant expressive language delay. So they will have either no words or minimal use of words. And the receptive skills and the nonverbal communication skills will be higher than the verbal ones. And it reminds me of the pair of twins that I saw in clinic. They're 12 years old, and none of them they're all nonverbal. So very severe speech delay. And the other thing that was interesting was the other girl that I saw in early intervention, the diagnostic. The girl was about 3 years old and close to 3, like 35 months, and she had no speech. She was always happy. She had the problems with the gait. So she met some of the clinical criteria. This is a girl I mentioned earlier that her lab genetic testing was normal. But this was something that we were like, is this autism? Is this a motor disorder? But then when you put the picture all together, then you can think, okay, maybe this is Angelman syndrome. So that's something to think about when you have a kid that, again, with these characteristics. 80% of them will frequently present with a delayed disproportionate growth in head circumference. So by the age of 2, we'll see a relative like microcephaly. And then the other thing that is really characteristic of this syndrome is the neurologic implication with a seizure disorder that we usually start before 3 years of age, and therefore you will see an abnormal EEG. So those were the consistent, which 100% of the cases will present. These are the frequent, and there are associated symptoms. So there's another big list of 20 to 80% of the kids could present with either frequent drooling, strabismus, difficulty with sleeping, and protruding tongue, just to mention some of them.
Okay, Cindy and Adam, we do have a couple of questions. The most recent question is from Debbie, and when you were talking about Angelman syndrome and the one brother laughing in response to the sibling's injury, it kind of led to a question of when the child with Angelman is injured or has pain, do they typically respond laughing, or will they respond appropriately with pain?
Yeah, so this is a good question. So for the most part, because they're always in a happy demeanor and they have this posture, so it's really hard to assess for pain in these kids. So we go more with the physical manifestation. So when you examine the kid and if you see other symptoms more objectively, like, you know, heart rate. And so these are things that obviously it's not going to be able to by a family member to identify as easier, like if you have measurements like doing a physical exam and having a pain scale. So the family members are usually, again, in a struggle to figure it out, is this something that is actually, does he have pain? So they have the bottom line is that they have a higher threshold for pain. So it's really challenging.
Thank you. There was also a question a little bit earlier on about when you were talking about Prader-Willi, and this might be for Cindy or Adam, I don't know, but the question was, do the variances in development level out later in life, or is this something that continues to be an issue throughout the rest of their life?
We will mention we will talk about developmental and behavioral outcomes, but if Adam wants to say anything about this at this time, if not, we'll cover most of their developmental outcomes in the next following slides.
Okay. Adam, was there anything you wanted to add there? Or?
No, Cindy did mention we will talk about outcomes here in a little bit. So I'll make sure that we get into that detail here later on.
Okay. There was another question that was when you had mentioned that I actually have. When you had mentioned dealing with insurance and everything, do you have difficulty with insurances covering dietitian assistance or anything like that?
Typically, diet care isn't really the big problem that we're dealing with. We're mostly dealing with growth hormone therapy. Pretty much, growth hormone is really a strong treatment that every Prader-Willi family that knows about it wants to get on. And pretty much universally, we all find out that the first time we send in a claim, it's immediately rejected. Our doctors even know that; they even work with us on that. But depending on what state you are and what type of insurance you have, it can become a real battle for a family to get growth hormone approved. It can kind of become all-consuming. So for diet needs, it's typically the insurance companies seem to be pretty good with it, but they typically don't want to pay for the expensive growth hormone injections.
Okay, thank you. Just a clarification, Karen had wanted to make sure that she understood what percentage of children go undiagnosed. I don't know if, I'm assuming based on the comment that it has to do with Prader-Willi. And so you had mentioned we thought 10 to 15%. Is that correct, Cindy, that that's about the percentage that come undiagnosed?
That's for Angelman Syndrome.
Do you know the percentage is for?
Are you referring to the genetic testing having 10 to 15% of the cases that are not detected by the genetic testing, or what's the question again?
I think that is the question. The exact wording of the question is what percentage goes undiagnosed. This individual has a client who's now 9, but when in EI workup was negative. Today she presents with increased weight gain and decreased speech. So I'm assuming that had to do with Prader-Willi, but I'm reading into the question. So, okay. Couple other questions here. Susan is curious as to do you use the growth hormone to help them achieve the milestones for the first year, and then how long for the growth hormone?
Yeah, so the growth hormone treatments are typically done throughout the growing years of the child. So we try to get them on there as soon as possible because it does help them start hitting milestones. So the earlier they get on it, the sooner they can start to get down the path of hitting the milestones. So most of the time the endocrinologist will try to get the child on it as soon as possible, and then they stay on growth hormone through their teenage years until they stop growing, really. Prader-Willi children are typically very short in stature. They're very short in, they have small hands, small feet, and very low muscle tone. So the growth hormone helps to combat all of that. And alongside a good diet, it doesn't contribute to obesity, but it does contribute to an increase in lean muscle mass. And I see, if I can, Maria, there's another question there, I think, for me about why is a low-carb diet used for Prader-Willi instead of calorie counting. A lot of families are doing both. The low-carb diet is pretty popular. A low-carb, high-fat, high-protein diet is getting good results in Prader-Willi kids because Prader-Willi kids in general have a really hard time breaking food down and converting it into energy. And that's why we don't want to feed them carbs, because carbs don't get converted to energy very easily in anybody. So we want to keep the carbs out of the body so that the calories that go through the body all get converted to energy as soon as possible and not converted into fat. Calorie counting is typically done alongside that too. The families who are good on the low-carb diet are typically also doing a good job on calorie counting. Any Prader-Willi kid, especially in the early intervention years, their family's paying a lot of attention to their height, their weight, and their length when they're infants, because we're really trying to keep them on the growth scale of a healthy child. So calorie counting is involved as part of that as the kid starts to gain weight.
Thank you so much for that information. That's all very, very helpful information. There are a couple other questions, but I'm actually going to kind of have to move us on so that we can get through the rest of the presentation. But I will come back to those questions if they haven't already been addressed in what Cindy and Adam share at the next question break. So Patty, Maria, just kind of hang on. And Debbie, I'll get to those questions in the next break. So Cindy?
Yes, thank you so much. So moving forward, we already have mentioned some of the common medical problems that these kids will have. So starting with Prader, actually, yeah, we have another question.
Yeah, so we do have another poll. So folks, the question that is presented to you is, which medical problem is usually seen with both syndromes? So you got 3 choices there. Open up your poll. That's right under your name. Here's your name. There's the poll function. So open that up and indicate from there. We'll give folks 10, 15 seconds to respond. All right. Good answers coming in. So let's see, we have the overwhelmingly folks have chosen feeding difficulties as the commonality between both syndromes. But let's see what the answer is. Oh, there we go, Cindy. And it does appear Cindy's mic is on a little bit of delay, so we'll give her a chance to catch up. All right. I'm hoping that those of you who participate in these webinars enjoy the opportunity to participate via the poll. Cindy, you want to try your mic again?
Can you hear me now?
We can.
Okay, great. So the medical problems are usually seen in both syndromes, feeding difficulties. And let's move forward. So as we already have mentioned a little bit of this, but just to go over again, so medical problems in Prader-Willi at this infant stage, so they will need assistance for feeding. It's described to be nearly universal in the first couple of months of life. We do have, again, after the onset of the hyperphagia, we have, again, a wide range of food-related behaviors, including actively food, eating non-food items, stealing money to buy food when they're older, and even running away from home to search for food in a wider area. So it's really important, as Adam mentioned, to control these behaviors, and some of the times including limiting access to food and locking cabinets or refrigerators. We mentioned also a little bit about the nutrition, so it's really important for these kids to maintain an adequate and appropriate nutrition. And initially, again, they will require support with feeding, and we'll see the failure to thrive, but then again, later we have to make sure that we maintain appropriate weight gain and have the caloric restriction, as Adam already mentioned. So the diet requires a careful monitoring and attention to the balance of essential nutrients. And this is often best achieved by, learning, educating our families, but also following with a dietitian and someone hopefully that could be knowledgeable about Prader-Willi. As part of the early intervention with all our kids that have any difficulties with developmental delays and so, we want to make sure that we have screeners for a good hearing and vision test. Some of the kids with this condition will present some abnormalities like cataracts or nystagmus, strabismus. So it's really important to refer them to a pediatric ophthalmologist if needed. And then with Angelman syndrome, the most important medical implications in this first 0 to 3 age range. So seizures is definitely, we see that in most than 90% of the individuals, and it's usually before age 12 months we will see that a good fourth of them will present, but most of them onset before the age of 3. So this could be any type of seizure disorder, and most of them require multiple anticonvulsant medications. We also see, as we mentioned, feeding difficulties. It's not as severe as we can see in kids with Prader-Willi, but they will have trouble sucking or swallowing. Sustaining breastfeeding could be a challenge. They could also have some frequent spitting up that may be interpreted as formula intolerance or reflux. They also present with oral motor behavior, so they put everything in their mouth, and they have this persistent tongue protrusion, and drooling is something that we frequently see as a persistent problem. They could also have some gait and movement disorders, so we mentioned a little bit when we were talking about the clinical criteria, but with these kids, we'll see that they have a delay in their gross motor skills. They start sitting when they're age 12 months, and they start walking between the ages of 3 and 5 years old. So there we could see a range. So some kids will be mildly impaired and have almost normal walking, but definitely it's something that we'll see in all of them. So physical therapy is really important to improve ambulation, and sometimes bracing or surgical interventions depending on the case may be needed. So moving forward, developmental and behavioral outcomes. Adam, you want to share your story?
Yep, so this is some more recent pictures of Graham here. That was Halloween on the left. He went as Clark Kent. And on the right is just a good picture of him. As you can see, he has glasses. Graham was born with really bad strabismus. When he was born, his pupils were going all over the place, so we knew right away that he needed some help there. So he actually had a surgery to correct that, to kind of realign his eyes. And then the glasses are there to help strengthen that out. And those glasses are really good assets for fundraising, by the way. If you put a picture of a kid with glasses, you can get a lot of checks sent your way. So we raise a lot of money for funding, for research funding. But other health concerns that are, you know, Prader-Willi kids have a lot of seizures too. We've been lucky we haven't had to deal with that. We do work on a lot of gait issues as well with Prader-Willi kids. Graham's been pretty strong there. A lot of Prader-Willi families, us included, use hippotherapy, which is therapeutic horseback riding, which works on the core a lot and helps out with a lot of those movements. So that's pretty common in the Prader-Willi community. So in the case of Graham, as he moved away from those infant years where feeding was an issue, as he's gotten older, our biggest issues have really been, one, just helping him to continue to hit milestones physically, like walking and occupational type milestones, but also two, speech has been a real challenge for us. And it's very common for a lot of Prader-Willi kids as they're supposed to get older and start talking and going off to school. Speech is typically one of the last milestones that they get caught up on. I've met, you know, dozens of Prader-Willi kids. I haven't met one yet that doesn't speak without some noticeable difficulty. In the case of Graham, he's now up to, he can say a lot of 2 or 3 word sentences now. He started doing, but it's taken him a long time, and he doesn't always complete words. He says things like hot instead of hot, or he says rough instead of dog, things like that. So he's really trying to get caught up on speech, but that's where we spend a lot of time with him. And he started school just this month, so he's making a lot of progress there. Yeah. So what else? What else do we have, Cindy? What else should I talk about here?
You want to talk about your, well, you have mentioned already a little bit of your early intervention experience with Graham.
Yeah, so for early intervention, you know, we're in the Illinois Early Intervention Program, and we basically get all the therapies. We get physical therapy, occupational therapy, speech, and nutrition. And he also saw a developmental therapist once every couple months. In terms of the physical therapist, we had a great experience. She came in about 2 times a week to start. When Graham was born, he had no muscle control. You know, they say that a Prader-Willi baby is born with low muscle tone. It's probably more accurate to think of it as no muscle tone. Like he couldn't pick up his head, he could barely lift up his arms and things like that. And through physical therapy now, he's able to walk around pretty good. He runs around and plays pretty good. So physical therapy was a big help with that. He spent a lot of time doing like ball exercises, like on top of an exercise ball when he was an infant, and he worked his way up from there. Occupational therapy, spent a lot of time with him working on things like blocks and sorting and threading string through blocks and that kind of stacking type activities, which took him a long time to get a handle on, but he's made a lot of progress there. And now that he's in school, he's trying to figure out how to write. His current goals are to get him to color. You know, he can only go side to side. We're trying to get him to go up and down, things like that. For developmental therapy, they really said that when he started hitting milestones, he really started to take off in a hurry. So his developmental therapist was very pleased. We didn't really see too much of her. But then that brings us to, and then our nutritionist, she works really good with us. We really liked her. But what you're going to find, I think, with Prader-Willi kids in early interventions is diet is so central to the treatment of our kids that we tend to get more educated on what we're doing than the nutritionists do. So, you know, that's an important therapy to get started with, but it's definitely something that the family, I think, in most cases, as long as they're able to, are going to start controlling themselves. And then the last one is speech, which is was in our case our biggest challenge. We went through about 3 speech therapists during our early intervention experience, just because we couldn't find one that really was making any progress. And maybe it wasn't fair to the therapists, but there were definitely times when we wanted kids to try things, or we wanted the therapist to try things that they weren't interested in. So once we moved from the speech therapy being focused on feeding, which happened probably about the year mark, we kind of stopped focusing on feeding and more on communication. It took us a long time to get any progress in speech. Graham didn't really start talking more until like his 2nd birthday. And we did use some sign language. He still has a couple signs that he gives us, and he can communicate very well. It's just not usually with words. It's usually more with gestures and sounds and pointing and things like that. So as we move forward here into the school years, Graham's very behind on speech. He's in a special needs program. He's in a mixed classroom, and it's largely speech that we need him to get caught up on that will allow us to get him into a traditional classroom and out of the special needs classroom. So that's what our focus is on now here as we age out of the early intervention years. Anything else, Cindy? Or?
I think that was great. Thank you so much for sharing that. So, we'll move forward, and I think he touched on pretty much everything in terms of the things that we have to consider in kids with Prader-Willi and their development. So we'll go over Angelman Syndrome, and this picture is from, again, from the media. This is Colin Farrell, the famous actor, and his son that has Angelman Syndrome. So in terms of their development, what he described, as we read here, that I almost broke in half when he took his first steps. So he also said, like, we share in the smallest victories. The first words were at age 6 or 7, being able to feed oneself at 19 and getting seizures under control. And then he mentioned that when James, again, what I mentioned, when he took his first steps, it was at age 4. And so as we mentioned with their development, so kids with Angelman syndrome will have severe developmental delays, and their cognitive skills, according to some of the literature reports, do not appear to develop beyond the age 12 to 14 months in some of the reports, and their expressive language, some of the kids will rarely exceed a 10 months of age, and generally between 4 and 8 months. So it's a very, very significant speech delay. And as I mentioned before, we found that all individuals with Angelman will have a better expressive, receptive language skills as opposed to their expressive. And then in terms of their behavior, as I mentioned before, a big percentage of these kids will present with autism spectrum disorders, and it's really challenging because since they have profound intellectual disabilities, it's been discussed if this is truly like we're seeing autism, or if it's the intellectual disability and not able to have a clear picture of it. So when they have when they're older, they start presenting more social enjoyment and a strong motivation to seek out adults. So their facial expressions and more positive vocalizations. So it says like the hardest will be in the period between 2 and 4 to have this better understanding of their behaviors, but definitely very challenging point. And then in terms of resources and support, I would love Adam to tell you a little bit about what's been helpful for them.
Sorry about that. Couldn't find the button. Yeah, so my wife, Katie, is actually the Illinois Vice President for the Illinois chapter of PWUSA, which is the top organization you see there, the Prader-Willi Syndrome Association of the U.S. That's an organization that's been around for, I think, about 20 plus years now, and they focus mostly on raising money for research, awareness, and they also spend a lot of time on providing services. So it's a pretty good group. The Foundation for Prader-Willi Research, which you see on the right-hand side there, I'm on the Leadership Council for that organization. That is an organization which focuses on cutting-edge research. We do a lot of fundraising to raise funds, not for a cure, because there's no one cure for Prader-Willi, but for many cures, because there are many issues involved in the syndrome. So we raise a lot of money to help get some dollars going there. As a rare disease, we have a hard time finding funding, but there's a lot of cutting-edge research that we are involved in. And there's some really great families that are involved in FPWR that we've gotten to know over the years. So if anybody has any need, I'd be happy to reach out. Reach out to me. I'll be happy to help you out with getting connected with any of these organizations.
So with resources and support moving forward for Angelman, it's pretty similar. So that's another quote from Corin Farrell, that when you're a parent of a child with special needs, it is important to feel that you're not alone. And they've done such a great job with both of these syndromes to have resources and supports for families. So we have here the Angelman Syndrome Foundation, which they're doing a lot this year. There's another foundation for Angelman Syndrome Therapeutics, and there's actually an International Day for Angelman, which was just not too long ago, on February 15th.
Before we wrap up, sorry, I was going to say before we wrap up, because I'd rather have this lovely picture of Graham up than the funky little picture about questions. So, but this is a good place for us to stop and ask questions. So there are several, and I'm going to try to lump them in here together. So several of these do relate to Prader-Willi and the diet issues. So the first one really has to deal with, does the child, is it a matter that they never feel full? Even though they never feel full, do they feel hungry, or do they feel content? Do they ever feel content with their intake?
Yeah, the answer is they never feel full. If you ask a Prader-Willi kid who is a little bit older and able to answer the question on their own, if you say, you know, I know one boy in particular, if you ask him, are you full, he will say, oh yeah, I am always hungry. A Prader-Willi kid is pretty much constantly thinking of food because they always feel hungry. Their brain doesn't send the signal to their stomach that they're full. What we can try to do to combat some of that is a Prader-Willi kid is going to learn about time faster than most kids, because typically what happens is we put them on a set feeding schedule so that they know they're going to eat breakfast at a certain time, they know they're going to have a snack at a certain time, they're going to have lunch at a certain time, and they're going to have dinner at a certain time. It helps if they know, okay, I only have to wait 2 hours before I get my next meal. And then they typically know how to look at a clock and say, okay, dinner time is at 6 o'clock, it's 4 o'clock right now, I know what time it is, right? So, yeah, Prader-Willi kids are constantly feeling full, and that's why Cindy showed that slide of the refrigerator that is chained and locked up. Unfortunately, that is a reality, particularly for a lot of adult Prader-Willi patients, that if you don't restrict their access to food, they will constantly be eating, and that's when you see the obesity and the real serious health problems start to manifest themselves.
Okay. Along kind of similar lines, there's a question about if there's an urge for high sensory input type food, so or the oral sensitivity, trying to just get that sensation. Is there a trend towards more crunchy or highly flavorful foods?
Yeah, we do see that. Like a crunchy food that's, you know, very kind of like exciting in the mouth, for lack of a better way of putting it, a Prader-Willi kid will love, because they love to eat so much that when they see something that really hits all their sensory, you know, when it really hits them, they really like it a lot. So as we try to control the diet, and we try to you know, maintain their weight, one thing that we do, especially in the early intervention years, if the child is learning how to eat for the first time, is we try to keep a lot of those foods out of their diet so they don't develop a taste for it. You know, Graham has never eaten like a potato chip because we don't want him to develop an affinity for it. So there is a lot of time that is spent on sensory issues. We don't want to put like colorful boxes of sugary cereal in front of him, because if he starts to relate to that, he'll start to seek that out instead of waiting for a meal with a nutritional, wholesome plate of food. He'll look for that kind of sensory type stuff. So yeah, that's a really good point.
Another question related to Angelmans, and this was from earlier from Patty. For those children who physically present like Angelmans, but genetically their testing is coming back normal, are those children being, do they have further genetic testing to look for other types of conditions that aren't typically run in a genetic test? And I think that's probably for Cindy.
Yes, there's actually, again, in that 10 to 15% of the cases, they'll do more specialized genetic testing and see if they're able to detect those differences in their again, genetic material. But for these kids, because we're aware of this, a clinical diagnosis, if they meet the criteria, will be enough.
Okay, and let's see, you'd already answered the question about signing. Let's see. Jen wants to know what are some strategies that you have wanted to use for speech and that you see help with the most improvement with speech. You'd mentioned, Adam, that there were some things that you wanted to try that that you were seeking support for. So were there things in particular that you were thinking about?
Yeah, so the therapy method that people are getting the best results of in the Prader-Willi community is the prompt method. If you're in speech, you know all about it. We had some problems where some of the early intervention therapists that were assigned to our case weren't interested in trying the prompt method because they believed that Graham's problems were more physical than they were than they were in his brain sending the signals to talk, which is what prompt addresses. So that's why we kind of went through a few therapists until we found one that was willing to work with us on that. But the prompt method is very successful. Pretty much everybody who seeks out that method starts to hit milestones a lot quicker with the Prader-Willi community. One thing that's also very common is in Prader-Willi is speech apraxia, which is usually diagnosed for a few years. So in the early intervention years, they're not really calling it speech apraxia yet, even though that's kind of what it's presenting itself as. We do wonder if Graham has that, and a lot of other families have that as well. So that's the kind of thing that you're looking at.
Okay. We have just another couple minutes left on our webinar, but there is one question here that I think is really very interesting, and I'm going to combine it. So their question was, do you have other children, and how do you relate the diet issues with restrictions with the children that don't have Prader-Willi? But even if you don't have other children, what about schools and being around other peers and birthday parties and all of that? How do you deal with that?
Yes, this is a huge question. Graham does have an older sister. He's got a 5-year-old sister named Kylie, who she is not on as restricted a diet as him. But in our case, you know, she's got to live her life too, so she gets to eat some certain things that Graham doesn't eat. And typically what we try to do, because Graham is going to live in a world that isn't, you know, tailor-made for his diet. So his sister does get to eat things that Graham doesn't get to eat. Sometimes that causes a lot of trouble because Graham wants to eat what his sister's eating, but he needs to learn how to go through his life seeing other people eat things that he's not allowed to eat, right? So, you know, his sister does have a bit of a restricted diet just because there's not a lot of food in our house that a normal 5-year-old girl would be eating. But overall, she does get to eat things that that Graham doesn't get to eat. And then that does go into school, and it goes into friends, and it goes into social events. You know, Graham can't really go to a birthday party that's going to have cookies and cupcakes sitting on a table that no one's watching, because he will try to eat as many of them as he can. And he will try to, you know, he will go for the things that he's not supposed to get. So when he goes to a party or if he goes to an overnight sleepover, we definitely, as parents, have to make sure that the hosts are on the same page with us and understand that, you know, he's got to eat a different treat than what everybody else is eating, and then you got to put your food away.